Welcome to Scrub In, a podcast where purpose meets care. We are more than just a podcast. We are real stories of hope, expert health advice, and inspiring conversations with the people behind the scrubs.
This podcast will leave you informed, inspired, and reminded of the purpose that connects us all. It's the voice of humanity in healthcare, uplifting, honest, and full of heart.
Featuring hosts Dr. Kendall Barton, Keisha Morris, and Alice Roush. You can listen and subscribe on Apple Podcasts, Spotify, Google Play, and YouTube. Or visit bayhealth.org/scrubin to learn more. Now, let's scrub in. Here's our next episode.
Hi, thanks for joining us for this episode of Scrub In. I'm Alice Roush, joined by Dr. Kendall Barton. It's 2026. Happy New Year. And thank you for our new listeners and our returning listeners for coming back again to join us.
Absolutely. Yes, Happy New Year to everyone. And we're going to jump right in with our quote of the day, which for today is, "Wherever the art of medicine is loved, there is also a love of humanity." And that's from Hippocrates himself.
That's a great quote to come from you.
Yeah, well, it's a new year, so we're starting things off strong.
Yes. Well, today's topic is fitting for the new year. It is January, it is respiratory illness season, and it is such a busy time of year for you and for our entire health system. And we're talking about Emergency Room 101, when to go and what to expect if you head to the emergency room.
It should be a very exciting topic, and we are very excited to talk to our two wonderful guests today. We have Kelly Schultz and Eric Laird joining us, both from the emergency department in their own respective regions. So go ahead and just introduce yourselves, tell the audience just who you are.
So I'm Kelly Schultz. I'm the senior nurse manager at our Bayhealth Kent Campus Emergency Department. I've been with Bayhealth for 17 years. I've been a registered nurse for much longer than that. I started in Chattanooga, Tennessee originally because that is where I'm from, as you can tell by the accent. I have been a nurse for a long time. I did a few other things, and then in 2006 landed in the ER and found my home, and have been an ER bedside nurse, a clinical coordinator, and a manager of a freestanding ER, and now the Kent campus.
And I'm Eric Laird. I'm the senior nurse manager of the Sussex ED, as well as the Sussex Clinical Observation Unit here at Bayhealth campus. I have been with Bayhealth for 16 years this year. Originally started with the organization as a certified nursing assistant on our old inpatient rehab unit at Milford Memorial, and transitioned to the emergency department in 2015. So I've been with them for 11 years now.
Thank you both for joining us today. I know it's such a busy time, so to have you here, we know it's something you're passionate about, sharing this information, and we really appreciate your time. Tell us a little bit about the why behind why you got into healthcare.
I've always said it's not what I do, it's what I am. It just kind of happened organically. I was a senior in high school, taking college prep classes, and they had like a career day, and I was walking through, and the School of Nursing at Cleveland State Community College was there, and I told them I was interested in being a nurse, and they're asking me like my GPA and my SAT scores, and I told them what my SAT scores were and that I intended to take it again, and she said, "Why?" And so I was accepted into the nursing program, and at the time there was a 2-year wait list, but I was accepted into the nursing program before I graduated high school, and I graduated and was a registered nurse by the time I was 20.
Wow.
Nice.
That's impressive.
Yeah, my why started similar to Kelly's. It was towards the senior year of my high school career. My mother spent a lot of time in the Bayhealth inpatient rehab unit with many orthopedic surgeries, and just kind of was in all of the nursing profession and the care that she was provided during that time. So ironically, that ended up being my first position with Bayhealth in that unit. So very much family driven, and that's still the drive for me today, right? The family and the familial bond within our teams and the EDs, I think, is just the real push for us. So.
And then, just for those curious listeners, myself included, how did you go from the bedside aspect of it into the managing side of nursing?
It just kind of happened to me. I ended up with a clinical coordinator position. I spent a short time in Arkansas and moved back from Arkansas to Tennessee, and it was a clinical coordinator role that I took at that time. And I guess I was kind of, some people are just born leaders. I just did the right things. I had been a charge nurse and just kind of continued to evolve as as a leader, I often say, I just want to take care of nursing. And as a nurse manager, that allows me to take care of the staff who take care of the patients. So that's how I ended up there.
Very similar situation. I ended up as a clinical coordinator in our Sussex ED in 2019. And I was very much in the decision-making process of, do I want to be a nurse admin? Do I want to lean more towards a nurse educator focus? The nice thing about the clinical coordinator role at that time is it kind of allowed both. So I really kind of gravitated more towards the leadership focus. I was supported, obviously, through my career. I started out with Bayhealth as a certified nursing assistant and kind of moved into that staff nurse position, the clinical coordinator position. So the professional drive for me is being able to support my colleagues and my team members in that same growth. So.
That's awesome. I appreciate you guys sharing. That's important information because I feel like so many of our listeners and people just in general who are not familiar with the field of medicine don't realize that there's so much more than just bedside care.
Absolutely.
You know, and that goes across the board from nursing all the way up to the top. So thanks for sharing that. Now, let's get into the real meat of the conversation. Help explain to our listeners, if they're trying to decide whether they need to go to the emergency room or an urgent care or call their primary care physician, what are the things they need to be looking out for to make that decision?
So you can always call your primary care doctor, regardless, whether it's a cold, a flu, you feel that like you've got the flu or whatever. You can always call your primary care just for some guidance on that. If you're having chest pain, heart attack symptoms, stroke symptoms, which would be like fast facial drooping, arm numbness, particularly one side, inability to use your arm, slurred speech, then timing is of the essence. So if you're having a stroke, if you're having a heart attack, if you have a history of congestive heart failure and you absolutely can't breathe, then you need to call 911 and get your care expedited quickly. Don't drive yourself and don't have someone drive you. The paramedics are there for a reason.
Yes.
Colds, sniffles, minor breaks would go to an urgent care. If you've got a break where your bone is exposed, clearly that is an emergency department visit. You've got a really deep laceration, you've nearly cut your arm off, certainly don't go to an urgent care with that.
I think Kelly touched on it's always good to reference the primary care physician, particularly this time of year. We see a lot of corresponding symptoms with the flu and what's shortness of breath versus what's your typical cold associated shortness of breath. So just having that conversation with the primary care is always a good basis just to make sure that you're heading in the right direction.
Anything that patients can do at home, say if it is something like they're worried they have the flu and their symptoms are somewhat severe but they're not sure, what makes it severe enough that they should go to the emergency room?
I think one of the things that primarily to look out for is high fevers, fevers that aren't being responsive to treatment at home, Tylenol, Motrin. High heart rates is another thing, and if you're having shortness of breath when you're walking, those types of things are certainly some things you want to follow up on.
And ongoing symptoms for a period of time. If you've been home for a week and you haven't been able to hold anything down, you could certainly be very dehydrated, which could lead to further complications. So if it's been an extended period of time and you're really just not getting better, then you might want to explore being seen by a physician.
That's great. And I think one of the tools that is really accessible nowadays is the smartwatch, which people can check their heart rate, they can check their oxygen saturation. Some of them even can do an EKG now at this point. So I think we also encourage patients to, check at home first, see how what you're feeling before you have a emergency room need to check that for you. So
Quick plug for our website as well, bayhealth.org has some specific information that might clarify where to go for your emergency or if it's an urgent care need. Also, we've shared that on our social media channels, so it could be a quick way for someone to reference instead of running through it in their head.
yeah, absolutely.
Well, and I wanted to say there are opportunities out there like virtual visits with your physician. We have a virtual physician that you can see, a virtual urgent care that you can see. And then, of course, go into an urgent care. If you go to the urgent care and it's wrong, they're going to send you to us. If you come to us at the ER, we never, ever turn anyone away. But if everybody comes to us, then that's kind of what leads into having wait times.
Leads into our next question is, what could you expect if you head to our emergency department?
So typically the first thing when you get to the emergency department is you're going to be screened with public safety. That's a safety mechanism that's built in, just to make sure that we've got the right people coming in and keeping everybody safe. From there, they're going to refer you over to registration, get the registration process started, which is really the beginning of the ED phase. That gets you on to our computer system so we can see your arrival, and then expedite you back to triage is the focus from there. Our triage nurse is very adept in identifying conditions that warrant emergency room visits, doing vital signs, and then really start in the beginning of that process, particularly if there's a wait. We can do EKGs, we can do blood work, we can do x-ray imaging, those types of things. Heavy focus right now on making sure that we have a provider out in triage that's evaluating the patients, because we recognize there's probably going to be a long wait right now.
And that is also one of the important reasons why, if it really is an emergency, like you mentioned, a stroke or a heart attack, to call 911, so that when you are treated, you're actually getting treatment right away, rather than waiting to go through security and going through those steps.
Yeah, agreed. We try to be as efficient as possible through the triage process. But with that being said, there's sometimes that ambulances, even though the patient may call 911, they may still end up in the waiting room. So just to recognize that, we work off of that prioritization system, and the emergency room is not a first come, first served basis. We do try to treat the most severe cases first.
So let me stop you there to clarify, because this is something we hear a lot, and people come in and say, well, hey, I came in, I cut my hand, and I've been waiting for an hour. These people just walked in and they had barely had to wait, and they were seen by a doctor right away. Why am I not as important as that patient? Can you help to try to clarify that?
Sure. We operate off of that triage system that we were talking about. So that takes into account the number of resources that we're going to utilize in the emergency department, also factors in the chief complaint, vital signs, those types of things. So there may be instances where we work off the acuity system. So 1 being the most severe, most emergent case, and a 5 being the least, with corresponding tiers in between there. Depending on where that tier falls and vital signs take into account, kind of dictates how quickly you're going to be seen.
And just like an anecdotal thing, people are, why did they get to come back first? And do you know what's wrong with that person? No, I do not. I do. They may look fine, but there could be other mitigating circumstances. They're having chest pain and they may be stoic. They're not thrashing about in pain. However, I have an EKG that says they might be in the middle of a heart attack. That person's got to come before any cut or bruise.
Yeah, I understand. I appreciate you explaining that. Justifiably, it's a pretty good reason to be frustrated when you're in pain or you're in discomfort and you're like, please, someone help me. But keeping in mind that.
Well, every single person that comes into the emergency department is having an emergency. Right. They are having their own personal emergency. It's not ours, it's theirs, and we do recognize that, but we are managing all, what was my census yesterday, 98? Yeah. We are managing all 98 of these emergencies, and you are not any less valuable or any less important. However, that laceration is not going to kill you. This heart attack might. And while I get that this is the most important thing to you, I still have to make the decision across the continuum of who needs care first.
Which I'm sure is incredibly tough. So we appreciate all that you do and all those tough decisions that you're making day in and day out.
Yeah, thank you. If somebody enters the emergency room, is there certain things they should bring with them on their path to be seen by a clinician?
Yes, a medication list. Some people bring the bag of medicines, which is helpful, but you also run the risk of losing an important resource that you're going to have at home. So a nice detailed list is always helpful. Any insurance cards and things like that, we don't care about the insurance on the front end. However, you're going to want to have that information at some point during your stay. We want to know as much as possible. So basically the sample concept. So what are your signs and symptoms? What allergies do you have? What medications do you take? Any past medical history? Any food? When was your last food and drink intake? In output, are you peeing and pooing okay? And then events leading up to making you decide to come to the emergency department. So all of that information are the things that we're going to ask for. And we may ask you the same thing over and over and over again, which can seem frustrating, but you may answer me differently than Eric and give more information based on the way you worded your answer that time. So multiple people are going to ask you the same thing, and it's not to annoy you or to make you be frustrated. It's just this is how we gather our data. So that's one of the complaints that we hear a lot of times. Don't tell me to call your doctor to find out what your medications are. It's your body. You put that stuff in there. You need to know what you take. So those kinds of things, I know that it's in there from your last visit. I need to make sure that there's nothing different going on. So engaging in sharing all of that information is most helpful.
Yeah, one other piece of advice is just anticipating that there might be something to do, right? Is it a book? Is it your cell phone charger way you can keep your phone charged while you're waiting? Just something to occupy the time.
So we've talked a lot about kind of the front end. What can patients expect once they get through triage? They're in the back now and the physician finally steps into the room. What are kind of the first steps there?
So they're gonna kind of go over what their anticipated course of care is, all of the tests that they intend to order, anything added on to, if you had orders on the front end, if we employed standing orders, anything that they wanted to add on, they're going to explain those things to you at that time. Before the physician comes into the room, you're going to see a nurse that will have settled you in the room, generally speaking. Get you settled in the room, get you on the monitor if it's appropriate, and any other standing orders that might happen, like IV fluids and things like that, can happen as well. And then you're going to wait again because you're waiting for your testing, you're waiting for the results, and it takes time for those things to happen. We try to share kind of an idea of, but if my CAT scanner is tied up with 5 traumas in a row, that's going to delay you getting to CAT scan because we need to get those emergent ones done a little bit quicker. And while, again, it's frustrating, we still have to prioritize who gets that resource first.
Well, we've mentioned that it's very busy, and I know you guys are both working very hard. What types of things are you doing behind the scenes that we may not even be aware of as patients coming in to help with this patient flow?
So this is a time that we call it surge. We're inundated with a lot of patients. We try to be creative because we have inpatients holding in our actual ED rooms, waiting for beds in the hospital, waiting for people to be discharged in the hospital. So that leaves us with emergency patients to see elsewhere. So you might be seen in a chair in the hallway. The physician and the nurses are going to have those conversations there. We may start your line and hang your fluids with an IV pole. You might be on a stretcher in the hallway. But we just have to be creative and find spaces that we try to keep everything as private as possible, using dividers, speaking quietly. If there happens to be a room open for a couple of minutes, we may swing you in there to have those conversations if they're a little more delicate. But we're just creative, and we are doing everything we can to ensure that people get seen as expeditiously as possible in spite of the fact that the ER is completely full.
Yeah. There's certainly an unconventional approach to trying to make sure that the patients are seen in a timely manner. We've been utilizing our triage space to try to have that nurse, if there is a little bit of a downtime, to expedite people from not even a treatment area, but directly up at the registration window, just to try to move them along. So if we have a lot of that testing back and it's been deemed that they've already been seen by one of our providers, we'll move them right out of the front space. So it's all hands on deck, if you will, to try to make those things happen.
In some cases, too, even having somebody sort of walk through the waiting areas to keep an eye on people.
Yeah, we do have people rounding in the waiting areas when we are higher capacity. They're taking vital signs to make sure that your vital signs haven't changed. Having folks check on you in that space. We have patient care liaisons who, fluff the pillows, so to speak. How can I help you? Can I get you? What can I do for you? Can I help you navigate this conversation? We do encourage people to advocate for themselves. Now, if you come up to the window every 5 minutes, that's really not helpful. But if there's a change in your condition and you're like, I was feeling kind of bad, but now I'm feeling really bad. Yeah. I need to let somebody know that. You were a little short of breath and now you cannot catch your breath. You need to alert somebody that, hey, there's a change in my condition while I'm sitting out here. So that way it's kind of a partnership because I'm looking to see everybody and I'm trying to see everybody, but my eyes can't be on every single human all at the same time, especially when we have this overabundance of patients.
I think something else really important to emphasize is the fact that this is not just an ED approach to this. Organizationally, the leadership is very supportive of us, as well as our colleagues from maybe the medical offices are coming in and helping us doing the rounds in the waiting room that Kelly's talking about, and revitalizing and making sure that we have eyes out there and communicate as effectively as possible.
We're ongoingly looking at the whole census at the hospitals, within the hospital and in the emergency departments to try to make sure that we're on top of getting people discharged from the hospital when it's appropriate. Increase physician staffing, increase nursing staffing, doing all the things that we can to try to expedite getting people out so that we can get people out of the ER to try to stop that bottleneck that kind of happens. So organizationally, everybody is working, like Eric said, all hands on deck.
And it impacts people, in the supply chain, making sure that we have extra supplies for, and even opening patient rooms that maybe didn't see patients throughout the hospital to help with you to discharge more patients, to give you more space eventually in the emergency room.
Absolutely.
Yep.
So we've heard a little bit about what patients can expect before they go to the emergency room, when they get there, then when they're seen. Hopefully most people are the situation where they can be treated in the emergency room and then sent home, but unfortunately not always the case. A lot of patients have to stick around. How do you guys in the emergency room then coordinate with the inpatient side of things to get a patient admitted?
So once a patient is admitted and there is a bed available, the bed will be assigned. However, inpatient care starts from the time those admission orders go in. One of the things that we have to help support us is inpatient nurses can come help take care of those patients, or emergency departments care for the inpatients, and we order your medications, we order your meals, we order your diet, so it turns into not emergency care anymore, but it's inpatient care. It's just in the setting of the emergency department.
The care really flips over to our inpatient hospitalist group after that admission piece. So they certainly help manage the ongoing care, despite the fact that patients may be dwelling in the emergency department with us.
When somebody has been waiting for a really long time, or what they perceive to be a long time, and they're tempted to leave and go seek care somewhere else, or maybe just go home because they don't feel well, how do you deal with a situation like that?
So we really don't want people to leave the emergency department once you arrive. You came to the emergency department for a reason. While you might not be seen as quickly as you anticipate or wanted to be seen, we've started your care, and we really don't want you to leave. And just remember, it's the same everywhere. If you leave me and go to Sussex campus, you're just going to start the process over again. It's not going to be you're not going to be seen any more quickly, and you're just going to delay your care, and your condition could deteriorate. And so now you're driving in your car and things get worse. So really, once you're there, the best bet is to just stay and let your care be completed.
You also never know when some of those situations are going to get worse out of nowhere, and hopefully they're already at the emergency room and not driving to a different place. So.
Precisely.
Right.
All right. Well, how about, so we've talked a lot about the whole process now, but where about where they can actually go? What are the services that Bayhealth offers around the area that we can explain to our patients?
Sure. We have 4 clinical ED sites, obviously Kent General, the Sussex Emergency Department. We also have Smyrna Freestanding ED in Smyrna, and then Bayhealth Total Care in Milton, Delaware.
Tell us a little bit about the difference with Bayhealth Total Care in Milton, Delaware.
Sure. Bayhealth Total Care is the only site in Delaware that is a hybrid ED. And with that is a model that you can go in as an ER patient, but based on the chief complaint in the workup, you may be billed as either an ER patient if there's, say, blood work, EKGs, CT, those types of things. But if you go for the flu swab because you're having viral symptoms and it's deemed that you have an urgent care visit, you'll be billed that way. So it's a courtesy billing, kind of built into the one system. So very unique, and certainly beneficial for our population. And if you're looking for just standalone urgent care, we have 2 options of the walk-in in Milford, as well as the walk-in up at Blue Hen at the old Blue Hen Mall.
Awesome. Lots of options.
Lots of options.
Well, is there anything else you want to share with us, our listeners, or the patients?
I think just an emphasis on maintaining kindness, right? That is the one thing that we see, and it's particularly disheartening to us because our staff go through troublesome times. Ever since COVID, I think there's just been a tendency to find more frustration, and some of that's reflected on our team members. And just maintaining the mindset that we genuinely want to prioritize care, but we have to do so in a manner that seeks the greater good versus maybe taking the time into account. So
Yeah, the squeaky wheel doesn't get the grease. It just takes more time. Every time I have to come to the window to talk to you because you're disgruntled and frustrated and you want to yell at somebody, that just takes more time away from me getting the things done in the back that I need to do so that you can have your turn in the back with the physician. So kindness is so important, and we are really not making you wait for the fun of it. We want you to be seen, treated, and discharged as expeditiously as possible. We don't want you to have to wait, but it is what it is.
Well, I know we appreciate what you guys do all day, every day. So thanks for joining us.
Thanks
Thank
for
you
having us.
Yeah.
Very much. Thank you for joining us. And that's a wrap for this episode of Scrub In.
Thanks for listening to Scrub In, where we bring purpose and care to every conversation.
If you enjoyed today's podcast, don't forget to subscribe, rate, and review on Apple Podcasts, Spotify, and wherever you listen.
Stay connected, stay informed, and stay inspired right here with Scrub In.